On behalf of the Match Coalition, I'd like to thank you all for joining us today for a very timely and very important discussion, data deficiency, how information is crucial to resolving the maternal health crisis. My name is David Gray. I'm the Director of Government Relations and Connected Health Policy at HIMSS. HIMSS is a global advisor, thought leader, and member association committed to reforming the global health ecosystem through the power of information. My name is David Gray. I'm the Director of Government Relations and Connected Health Policy at HIMSS. HIMSS is a global advisor, thought leader, and member association committed to reforming the global health ecosystem through the power of information technology. I am also very honored to serve as one of the co-chairs of the Maternal Applications of Technology for Community Health, or the Match Coalition, the host of today's briefing. The Match Coalition is a leading advisor on the topic of digital health for improving healthcare conditions and outcomes for pregnant women. Our membership is composed of a diverse group of stakeholders from across the health and life sciences community and is free and open to all who support the mission and objectives. The primary goal of Match is to promote policies, guidelines, and regulations that support the adoption and application of clinically appropriate technology for the betterment of maternal health outcomes by fostering activities in the areas of research, education, and innovation. If you'd like to learn more about the Match Coalition or find ways to get involved, I strongly urge you to visit our website, matchcoalition.us. I also just want to make a quick plug that today is the first day of HIMSS Global Health Equity Week, which is dedicated to elevating global conversations around access to care and engaging in actionable steps to improve health equity and eliminate health disparities. I'm really excited that our event today unofficially kicks off Global Health Equity Week because our discussion around maternal health data really underscores why we need to keep prioritizing conversations around health equity and health disparities and ultimately lead to action. I'm sure you've all heard these numbers before, but I think it's important that we continue to say it until things change. But every year in the US, hundreds of women die due to pregnancy-related complications and thousands more suffer serious injury, with people of color and particularly Black and Indigenous women disproportionately affected. Many of these deaths and injuries are preventable. Despite the growing national attention, the maternal mortality crisis has only gotten worse over the years. While no single cause is to blame, one reason that really stands out is the lack of adequate data collection and reporting. It's true across all sectors, but particularly in healthcare, that more and better data and information leads to better outcomes. With greater access to accurate and quality maternal health data, healthcare providers, public health professionals, and policymakers can better focus on understanding the root causes for maternal mortality and outcome disparities and find solutions to end the crisis. In recent years, Congress has taken some significant steps toward addressing the issue, such as passing the Preventing Maternal Deaths Act, which was actually led by the boss of one of our speakers today, Congresswoman Herrera Butler. And there are a number of really promising legislative proposals that are making moves in the 117th Congress, but as always, more work needs to be done. I don't want to take up any more time. We have an excellent program, but before we jump right in, I just want to go over a few housekeeping items. Today's briefing is being recorded, so if anyone has any colleagues that couldn't join, we'll be sure to share the recording far and wide. We also hope to have plenty of time at the end for questions, so we encourage everyone to take full advantage of the Q&A function. When submitting a question, please include your name and organization or office. Jumping right into our program, we have brief remarks by Congresswoman Lauren Underwood. Unfortunately, the Congresswoman couldn't join us live today, but she was kind enough to send some pre-recorded remarks, which I believe we have teed up.
Hi, everybody. I'm Congresswoman Lauren Underwood, and I have the honor of representing Illinois' 14th Congressional District. And I'm a co-founder and co-chair of the Black Maternal Health Caucus. I'm excited to be joining you for this important briefing on the crucial role of data in addressing our nation's maternal health crisis. I would like to thank the Match Coalition for the invitation to join today's event and for your ongoing efforts to leverage technology to improve maternal health outcomes and reduce racial and ethnic disparities. I'm especially grateful for your support of my Black Maternal Health Omnibus Act, a suite of 12 bills that includes investments to support community-based organizations, grow and diversify the perinatal workforce, and address social determinants of health like housing, nutrition, and environmental conditions. I was thrilled to see these critical investments included in the Build Back Better Act legislation advanced in the House of Representatives. And I look forward to working with my colleagues in the House, Senate, and White House to get this legislation across the finish line. One specific title of the Momnibus that is especially important is the Data to Save Moms Act, led by Representative Sharice Davids and Senator Tina Smith. The Data to Save Moms Act will require a comprehensive review of maternal health data collection processes and quality measures, ensuring that we're gathering the evidence base that we need to inform effective policies and programs to reduce maternal mortality, morbidity, and disparities. Also included within the bill is funding to promote diverse community engagement in maternal mortality review committees and resources for minority-serving institutions to conduct maternal health research. These important investments were included in the Build Back Better Act legislation that advanced in the House as well, and we need to get them passed and signed into law. Thank you for all your support on the Momnibus and on this important mission to save moms' lives, end disparities, and advance true birth equity across the United States. I look forward to the day that we're back together again in person, but until then, take good care of yourselves.
Thank you to Congresswoman Underwood and her staff for facilitating that video. I think that's a really positive message to kick off this program. Next up, we are delighted to be joined by Congresswoman Sharice Davids, representing the 3rd District of Kansas for a fireside chat. When she was sworn into the 116th Congress, Congresswoman Davids became one of the first 2 Native American women to serve in Congress. She sits on the Committee on Transportation and Infrastructure, where she serves as vice chair, as well as the Committee on Small Business and the Joint Economic Committee. Additionally, Congresswoman Davids serves as the co-chair on both the Congressional LGBT Equality Caucus and the Congressional Native American Caucus. Joining her for the fireside chat is award-winning journalist Nina Martin, who is a features editor for Reveal, where she develops high-impact investigative reporting projects for Reveal's digital and audio platforms and television and print partners. Before that, she was a reporter covering sex and gender issues for ProPublica, including the groundbreaking Lost Mother series on maternal mortality with NPR. Thank you both so much for joining us. And if you'd please turn on your cameras, I will turn the floor over to you.
Thank you so much, David, for having us. It's very good. Hello. Thank you for inviting us to have this chat and for me to moderate it. Representative, my first question is just pretty basic. What is your particular interest in maternal health, especially the data issues around maternal health? How did you come to this topic?
Yeah, well, I appreciate you asking, and also definitely appreciate the chance for me to just be here and contribute to this discussion on maternal health. Because I think that right now what we're facing just this crisis around maternal health in this country, and that's particularly true for Black and Brown, Indigenous people, and frankly, it's a bit shameful that we're in this situation where we're failing so many people as their families are growing or they're having children. So I'm glad that we're convening to discuss the ways that we can address it. And, for me particularly, I would say that there's definitely a strong desire to address the disparity that exists, just knowing that Black parents and Native parents have just like consistently and constantly the need to to be protected, and for us to figure out what exactly is going wrong is something that's of personal importance to me. And it's why I'm so glad that I get the chance to work with, Congresswoman Underwood and Adams, because they're like amazing leaders in this space as well.
Yeah. So I started reporting on maternal health in about 2016. And at the time, it was kind of well known that the disparities in maternal deaths and severe injuries, severe childbirth related and pregnancy related injury and morbidity was really high amongst Black mothers, Black women. Native women hardly came into the conversation at that point. The data really wasn't there. It was really only, it seems to me, within the last couple of years that there's been a recognition that Indigenous mothers are also dying at rates twice the rate of white mothers. What do you see as the big lapses in data that exist right now that kind of have existed, and how would getting better data, do you think, what are the critical reasons we need it? How would that help address the maternal health crisis in this country, especially for Indigenous women and Black women?
Yeah, so I think there's a couple of things. Well, first I'll talk a little bit about the Data to Save Moms Act and that piece of it. Oops. There's a couple of really important titles in the bill. Like the Momnibus as a whole, and the Data to Save Moms Act is a piece of that. And that what we're really doing is building on a 2018 law that's called Preventing Maternal Deaths Act. And that was a bipartisan bill. It provided funding to what's called maternal mortality review committees. And as I'm saying this, I'm realizing I think I'm talking to a lot of folks who probably are like, yeah, we already know this stuff. So sorry if I'm preaching to the choir a bit here, but MMRCs exist in states across the country, and the Data to Save Moms Act builds on that by promoting more community engagement in these MMRCs. Because when you ask the question, like what are we trying to address, that the issues that have existed, but where the existing law or framework wasn't really getting to the root of the issue. And I think including community engagement in the MMRCs is a really important piece of that. And then also just kind of improvements in data collection processes, and then the quality measures that we're talking about. The data piece is not just what are the numbers, it's also like which pieces of data are we trying to get at. And I think the last and maybe sub point of that is that the Data to Save Moms Act has in it the first ever comprehensive study to understand the scope of the maternal health crisis in the Native community, and then provides funding to establish the first tribal MMRC, because that hasn't existed before. And ultimately the goal here is to better understand the causes of this crisis, and then have that really inform the solutions to be able to address it.
Yeah.
Is that clear? I think that answers the question. Yes.
Okay. Yeah. No. Absolutely. I was really struck, in fact, by this issue of creating the study for tribal to understand maternal mortality and maternal health issues in the Indigenous population in the U.S. In lots of different ways. It was one of those things where the lack of sort of seeing it in the bill made me really realize how it really doesn't exist. It hasn't existed, and it's super important. I mean, what if you had to choose one thing that is problematic in terms of how data is thought about for just Native population? What would it be? What something that jumped out at me was kind of you made really clear in the report in the bill also to really include mental health issues and substance issues, kinds of sort of issues that traditionally haven't been considered maternal mortality, and yet we know from other studies are really very much related to maternal health and.
Yeah. So I think I like that question. I think that one of the things that's really important is, so community engagement is one piece that I think, that I think now more and more people recognize that, to truly get at the root of issues or address something that is a crisis, that you should probably be engaged with the community and people who are like living the impacts and effects of that. And that kind of hasn't always been the approach, particularly from the federal level. And I think that for Native communities, for tribal communities, there's certainly the need to engage, and so that's one piece that I think is really important, that certainly informs the data, but is often kind of missed in terms of, so a lot, I think of the difference between engaging with a community or just observing a community. And so that's one piece that I have. And the nice thing about that, about thinking about it in that way, is that that will benefit not just the Native communities, but also other communities that have been impacted here. And, I think that making sure that we've got the framework there to increase funding so that there can be racially, ethnically, geographically, professionally diverse members of these different committees is really important. And then also thinking about the like what I'll call non-clinical factors. And you kind of started to touch on those. And I say non-clinical, meaning just the very specific, like, prenatal and like, postnatal part of it. So socioeconomic determinants of health, mental and behavioral health access, the stressors of life, all the kind of wraparound stuff. I think that those are the things that we also have to really get a better handle on. And, the fact that this bill provides mechanisms to make those things happen, I think it's going to be a key part of how we not just understand what is the root of the issues that we're trying to tackle, but also get really solid ideas and frameworks for how we address those issues.
I was also struck by the inclusion of specifically trying to gather information on the Indian Health Service, because again, we're sort of used to the ideas we've talked about, women, low-income women of color kind of being shunted into certain kinds of hospitals and certain systems. But of course, the Indian Health Service has its own problems, and it's rarely been kind of looked at in the context of all of this. So that's really also struck me. Okay, so a lot going on. Go ahead, sorry.
Oh, no, well, the other thing I was going to say that I think is really interesting that highlights is this idea of the kind of silos that end up happening, and just trying to make sure that we're, I do feel like the Data to Save Moms Act, but also the Momnibus, there's this holistic approach that I think we more and more we're recognizing needs to take place, at least from the federal perspective, that there has to be more of a holistic look at these issues. And so yeah, and the example you just gave about Indian Health Service or IHS, I think is a really good example of how that can end up happening.
Yeah, yeah. So there's a lot going on in Congress these days, and for those of us who are outside it, it looks a bit daunting and doomy and gloomy. There has been, however, activity in the House in advancing standalone bills from the Momnibus package. So, including your bill, I think, which was included in the version of the Build Back Better reconciliation package. Is that right? So, Congress is divided. It can be really hard to pass any kind of meaningful legislation. How does it look for you for this bill in particular, and maybe some of the other pieces, realistically, as we see what's happening in Congress?
Well, that's the multi-trillion-dollar question, I feel like. Okay. So I think that, first of all, I'm feeling optimistic because, and I mean, I don't walk around with rose-colored glasses on or anything, but I am feeling optimistic. I feel like there are, in a lot of ways, like a new momentum for getting some of this stuff done. And I say that in part because, the pandemic has had such devastating impacts on so many people that it in some instances have exposed gaps, in some instances have exacerbated them. And we're talking about everything from like health and housing to workforce issues and infrastructure that, I think are at this place where there's so much more recognition of how much we need to get things done, that I know there's like the back and forth and negotiation process that's happening, but it's happening, and I think that continuing to value caregivers and pregnant people who are like raising our next generations, that is something that like people broadly, and certainly people in the Kansas Third and the folks that I'm hearing from, are constantly talking about. And I do think that, with so many people reaching out to their electeds, and with, of course, with people like Lauren Underwood and Alma Adams, like pushing for this stuff, I think we're going to see some really, really great progress on this stuff. And I mean, I'm feeling, realistically optimistic about it.
That's great. That's great to hear. One thing certainly has been true about COVID is that it's exposed, as you say, and exacerbated a lot of issues, but one of them is around maternal health. And in fact, the data collection around sort of how, from the beginning of the pandemic, understanding how this virus affected moms, pregnant women and new mothers and babies, and then also kind of what those impacts might be going forward has been something that's been really not very studied. We were not in a very good position to study. And I'm wondering, obviously COVID has had a lot of other direct and indirect consequences for maternal health: reduced prenatal care visits, increased mental health issues, just all of the strains that new mothers, especially women who've just given birth, who haven't had access to all the already not great support systems that used to exist. So do you think has the specific issues specifically around maternal health and COVID? Obviously, COVID has had huge impacts on many communities of color, and Native communities in particular, I think have the highest death rate of any group in the country. Like, how has that sort of affected people's thinking about this in Congress and elsewhere?
Yeah, so I think first I'll kind of say kind of from my own personal view of things, which is that, I think a lot of folks like me read some of the statistics and recounting of how many young people have lost their either primary caregiver or one of them, if they have more than one, parent or guardian. And I think that this is a huge example of the reason it matters for our legislators and policymakers, one, to be listening to communities, but also to have this kind of broad, diverse background of experiences, because we know how devastating this has been on our communities, and that helps us as we're coming up with what are the things that we need to be thinking about. And the Momnibus, although it started pre-pandemic, the push for this started pre-pandemic, and we're building off of stuff, like I said earlier, we're building off of existing legislation and just kind of improving certain pieces of programs that have existed. But I do think that where we're at right now is, one, we have a lot of folks who are in the House. I came in 2018 with literally the most diverse group of people ever to show up to Congress. Mm-hmm. And I think that where we're at now is that we have so many people who are who aren't so wedded to the way that it exists now, and are saying hey, actually, if we really want to address these issues, we need to be in the communities, talking to the folks who are impacted by this and the experts from the community. Members of Congress are not the ones who are going to come up with the most amazing ideas for how to solve some of the biggest problems we're facing. It's the people who have that expertise and community experience that are going to come up with those things. And we're taking that holistic approach. And I feel like personally, what I'm seeing is more and more of that. And the pandemic just, in a lot of ways, it just sped up to me, it sped up the recognition from so many other people that that's what we needed to be doing, because we found ourselves in this unprecedented crisis. And so taking the opportunity to do that. And then from the broader, as Congress perspective, I think we have the benefit of a president who recognizes that we can call it lots of things, but that if we're not thinking about families as we build back from this crisis, that our country is going to really we're not going to get to where we want to go. That we have to be thinking about families. We have to be thinking about our caregivers and that sort of thing. So I feel like we're coming at it from all angles.
Yeah.
And yeah.
That's great. One last question, which is just where are we on the bill? So what's the next step on your bill in particular?
What was that?
On your bill in particular, on your piece of the Momnibus in particular.
Yeah, I mean, I think that the nice thing is when it comes to maternal health, and also infant mortality and issues, that we're usually able to get more bipartisan support, because we know that this is an area where it impacts all of our communities, and I think that I think we've got a lot of momentum. The bill came out of Energy and Commerce, and we've got the companion on the Senate side. So I think we're in a pretty good spot to hopefully get it onto the president's desk in not too long.
Okay, great. Thank you so much, Representative Davids. It's been really great to speak with you. I think we've hit our time limit, and you, I know, have to go back and make bills and all that. Thank you, really, for the work that you've done in this, and it's been lovely to speak with you.
Yeah, same here, and thanks for the time, and thanks for the work you're doing.
Okay. Bye-bye, everybody.
Talk to you soon.
Next up, I'd like to welcome Blake Margraf, co-founder and CEO at CareSignal, to share their experiences on the use of technology in addressing social determinants of health factors and improving maternal health. CareSignal is a deviceless remote patient monitoring platform that engages large patient populations through evidence-based automated texts and phone calls. I'm also proud to say that they are the winner of the 2021 HIMSS Global Maternal Health Tech Challenge. So Mr. Margraf, the floor is yours.
David, thank you so much. Thanks to the entire Match Coalition for your time, and for everyone for your collaboration on this important topic. So I'm Blake Margraf. I'd like to recognize my fantastic teammate, Erica Halsey, who was the impetus for our participation in this Maternal Healthcare Innovation Challenge. And with that, let's go ahead and dive right in. So what I'd like to do today is share with you one of the key problems hindering the adoption of maternal health innovation, especially from a technology perspective, which is, of course, social determinants of health. And then I'd like to share 3 very simple learnings that our company has discovered with many years and hundreds of thousands of patients worth of support that hopefully others can carry forward as our nation invests more and more in this topic. We'll end, if we have time, with some optimistic future opportunities as well. So stepping back, defining terms, social determinants of health. These are the subclinical factors that can be just as important for the health of patients as the clinical diagnoses or disease management approaches that are provided for those patients, for instance, for new mothers. And as is the theme of today's presentation, the data backing social determinants of health, especially for patients out there in the real world, the data are often missing altogether. And of course, that leads us right into the problem, which is that poor social determinants of health management for new mothers and children can be a major driver of poor outcomes. Social determinants of health is really a modulator or driver of health. And that means that it's part of one of the fundamental realities that can make or break the clinical future for any given patient. It's even more important for maternal care, because maternal care determines both the maternal and child health outcome, and it often impacts outcomes for the rest of the family. And that's not opinion in any sense. That's a pretty robust body of literature that aligns with that statement. And research, including research published just over the past several months, shows that poor social determinants of health management for new mothers and children, as illustrated by these bullets, has some pretty dire consequences. It drives health inequity for especially the disadvantaged populations. Essentially, those that are already at a disadvantage are going to struggle further. It accelerates the development and subsequent detrimental impacts of chronic conditions. And it harms the quality and quantity of healthy years lived by the mother and child. And that should be material to all of us, because that's detrimental to the financial productivity of individuals, of our communities, of our entire nation. This is an opportunity to get in at the ground floor of health for individuals who need it most. And at Care Signal, as I mentioned, we've had the privilege of serving hundreds of thousands of the folks who need support the most. And we've been fortunate to come across a few learnings that we apply in our own product and innovation development that hopefully everyone on this call can carry forward as well. The first key learning is somewhat intuitive. It is make sure that the technology or solutions you develop are accessible. And I would differentiate here between technology being in hand, which is a good first step, and technology being truly accessible. Just because a patient owns a cell phone does not mean that that patient is going to access better, more mobile remote care. And accessibility has a few attributes. First, it includes economic accessibility, and I'll describe that in a moment. Next, accessibility from a literacy perspective, literally making sure that individuals are able to consume the content or questions that are sent to them. And third and finally is behavioral accessibility, which we'll examine in the second key learning. One of the highlights of economic accessibility, especially for mobile health and mobile health care delivery, is just making sure that patients can literally receive messages via cell phone and respond to those messages. And that might be something that we take for granted, many of us, but for phones that run out of minutes a few days into the month, that can be a major limiting factor that can cause patients to turn through cell phones and become even harder to reach. And of course, for populations that might not be literate, we still need to find a way to reach those folks. That's where good old-fashioned phone calls can really be quite powerful. It goes without saying, the natural extension is making sure that those messages are coming not only in the appropriate language, but at the appropriate reading level to meet patients where they are. And with that, I'd like to move to the second learning and kind of expand on the concept of behavioral accessibility here. And the second key learning is that patient activation is utterly crucial. As anyone who has spent significant time in healthcare recognizes, the patients who need the most support are often the least likely to ask for that support, the least likely to self-advocate. And that self-advocacy is further hindered in new mothers who can easily feel judged. And some of the drivers there are cultural differences, self-criticality, even though it's completely unfounded, and unfortunately, some persistent racial inequities that are part of the healthcare system as we slowly get better in that regard as well. However, again, this is an optimistic view, right? The right technology can overcome many of those obstacles at once. Patient-centric technology that's designed from a patient's point of view, can improve specific health literacy, not by requiring a patient to take a graduate course on internal medicine, but by posing the right questions to the patient at the right time, all with very simple interaction structures. An example that I'd offer there about specific health literacy as opposed to broad-based health literacy might be that new mothers might not know that they should expect their baby to lose weight, to burn some of that baby fat in the days postpartum, days and weeks postpartum. And mothers might become worried that they're not doing a good job, that breastfeeding isn't working, and they might switch to formula just days after giving birth because they don't have access to that very specific piece of health literacy. From a social determinants of health perspective, new mothers might not even assess physical safety for themselves, put themselves first on a periodic basis. And the right social determinants of health screening can make sure that they do keep that in mind. And of course, that's going to benefit them and babies' health in the long term. Also on this topic, the right technology can move patients away from a wait until it's broken healthcare interaction mindset and can shift those new mothers and families toward proactive preventative engagement with existing resources. And a fun example here is for Care Signal's perinatal mood anxiety disorder program that used to be called postpartum depression. It took us 8 iterations to design a program that didn't feel judgmental from the mother's perspective. But once we figured that out, the benefits were many. The relationships improved. We're making great progress here. I'd like to move next to the third and final key learning, which is that building solutions that achieve adoption in the US healthcare framework requires evidence. And I won't pull everyone through the entire extremely rigorous journey that we take, but let me summarize maybe the 4 main steps to an evidence-based approach for technology. And you'll notice some similarities here to areas like pharma and devices, even though those are completely different regulated areas of healthcare. And building evidence starts, of course, with a robust literature review, what you see on the left, collecting and analyzing existing research, making sure that you understand what the standard of care is and why it exists, and then move into very hands-on, low sample size, iterative research. This can be as simple as writing some code, running the program with 8 patients, and then trying again. Then move toward alignment with incentive structures, that third quadrant that you see, because it's not enough just to have something that works well from a healthcare perspective. We need to be pragmatic. We need to recognize that sustainable solutions are not just clinically sustainable, they're also financially sustainable for the associated organizations serving these patients, these new mothers. And then finally, a combination of real-world validation and academic independent validation. Ideally, these are run in parallel throughout, or at least at time of launch. But this is what I would describe as a pragmatic, parallelized evidence capture approach that stands to accelerate the adoption of new and innovative technologies in the market. And in my last 30 seconds or so here, I'd highlight a few opportunities that are coming down the pipe broadly across healthcare as extremely compelling. The first is the opportunity for artificial intelligence to predict and prevent avoidable and undesirable events, both on a subclinical and a clinical basis. This could be everything from making sure patients stay engaged with their remote monitoring programs long-term to helping identify major risks for deterioration, for challenging populations. For instance, mothers that might be on track to really struggle with childcare in the coming months, and then flag those individuals. The second bullet is integrating population health, a relatively well-established and highly impactful segment of healthcare technology, and integrating that with the slightly more nascent patient-facing remote monitoring offerings that are coming to market. And finally, and this is really the theme of the hour, accelerating data capture and inclusion of social determinants of health in whole patient care. And I'm so excited to humbly serve a small part of that innovation. And again, to Match and HIMSS, I appreciate this opportunity. It's a privilege to join you today. Thank you.
Thank you so much for sharing these insights with us, and congratulations again on winning the 2021 HIMSS Global Maternal Health Tech Challenge. With that brings us to our panel discussion, and I'd like to welcome my fellow Match co-chair and all-around maternal health champion, Fran Ayala Somayajula, to introduce her panelists.
All right. It's a pleasure to be here with everyone, and I'm honored to be able to introduce you to our esteemed panel. We have Adriana Lagorio, who is the Senior Legislative Assistant to Representative Jamie Herrera Butler, who is the Republican representative for the state of Washington. Dr. Mariah Cranes, who is a program director for Cradle Kansas City, as well as Dr. Jeff Wall, who is an obstetrician gynecologist currently with Cerner as their senior director for clinical informatics, and Deb Kilday, who is a longtime experienced registered nurse whose focus is in the area of women and infant services line at Premier. With this, we're going to get started. Our roundtable today is to really deep dive further into this conversation around the opportunity that exists with the delivery of better care through access to more comprehensive data. And to get a real good appreciation for what this means, I'm pleased to have Deb Kilday to be able to kick us off with her experience and the projects that her team has been working. Folks, this is going to be an amazing presentation, as we'll be seeing for the first time data that's been seen nowhere else. So Deb, take it away.
Thank you, Fran, and good afternoon, everyone. It's absolutely a privilege to be with you all today. And we'll start a little bit on the background and how we are bringing this data to you. It'll be just a snapshot of some data that we're providing to Health and Human Services in the Office on Women's Health, who at the end of last year laid out a vision for the U.S. in maternal health. They provided an action plan on the current state of maternal infant health outcomes and challenges around reducing maternal mortality and morbidity. This was combined with a Surgeon General call to action to improve maternal health and outline strategies for diverse groups from across the country that were brought together in a forum to share what we're doing to impact the maternal infant health crisis in the U.S. So a component of their initiative includes the partnership with Premier, and Premier is a healthcare improvement organization with more than 4,400 hospitals across the country. And we serve approximately over 200,000 provider organizations, along with Mama's Voices in this partnership, which is a coalition of more than 20 patient advocacy organizations. We are providing a two-pronged approach to support HHS with their goals. The first is what we're going to share with you today, the maternal infant analysis, national analysis. This is derived from Premier's nationally representative research database, where approximately 45% of the U.S. discharges inpatient, outpatient within the acute care setting are collected. And we're analyzing the factors around maternal infant mortality and morbidity, and this includes looking at race, ethnicity, and all the way down to socioeconomic factors and comorbidities. The second, briefly, we are not covering in today's presentation, but it'll be exciting data that we'll be able to provide to you in the near future. It's to establish a cohort of 220 hospitals from all 50 states in the District of Columbia. We actually formally launched that national collaborative last week. It is a very nationally representative sample of hospitals from across the country. They're going to work together to implement standardized care practices and processes of 23 maternal infant areas of focus that are aligned not only with the hospital's quality improvement efforts, but aligned with national and state strategies. And that includes the AIM programs, so those facilities can support their national AIM programs. This initiative directly measures over 150 different metrics that align to those 23 maternal infant areas of focus, provides those hospitals with very detailed data that they can drill into around each one of their implementation strategies, and provides HHS and the Office on Women's Health with anonymous, de-identified, aggregated data from all 220 hospitals, which includes social determinant of health data, opportunities to identify health equities, and is a linked maternal infant analysis. So the health outcomes of the mother will be directly reflected on the health outcomes of the infant. The analysis that we're about to show you now is from the research database that I mentioned a moment ago. We leverage a research database that's 20 years deep. As mentioned, it's a standardized inpatient, outpatient data collection system with more than 1 billion patient encounters, which equates to about 25% of U.S. birthing discharges. So the all patient-related data in the PhD is de-identified and HIPAA compliant from both the inpatient hospital and outpatient hospital settings. It includes demographic, disease state, and information on billed services, which makes it a little unique, and it includes things like medications, laboratory tests, diagnostic tests, and other features. For HHS, we looked, again, at an average of about 1 million births a year across 45 states and nearly 1,000 hospitals. The slides to move here for you. The analysis, or the objective of the analysis that we're sharing with you today, was to examine specifically and identify risk factors of outcomes and disparities and assess COVID-19 impact on maternal mortality and morbidity. The patient demographics and clinical outcomes were measured using the CDC's methodology for severe maternal morbidity, which includes the birth volume denominator and numerator that they use within their studies. We specifically looked at maternal outcomes that we're about to share with you at the time of delivery. We have a very comprehensive analysis for both the maternal and infant populations across the continuum, but what I'm about to show you is a very small snapshot of outcomes at the time of delivery and how this example of data may be able to help support some of the gaps in data within healthcare. So on this slide, there's some really good news, and hospitals should be proud of themselves across the country because they've been making an impact on delivery-related deaths. We've seen a decreasing trend with the in-hospital mortality at the time of delivery after adjusting for changes in patient demographic, visit, hospital, and clinical characteristics. This study took place between 2008 and 2020, the fourth quarter of 2020. You'll see that we provided for you on these slides both the regression adjusted trends in addition to the unadjusted trends so that you could see the unadjusted compared to the adjusted trends. So overall, maternal mortality in the United States is decreasing at the time of delivery. I'll go back one more slide. Here we have a regression analysis related to in-hospital mortality, looking at race and ethnicity, and we identified disparities among mortality, although it has improved greatly over time. You can see Native American women have made the greatest amount of improvement over time with a drop from 58.3 per 100,000 discharges to 2.2. There still, again, is some disparity associated with delivery-related mortality, but it is improving overall. When drilling into data, we have the capability to drill. This is a very brief presentation, so we won't go too deep, but you can see when we uncover some of the delivery-related factors we identified, for example, Medicaid payers were attributed with 57% higher odds of mortality compared to commercial payers, that we know that cesarean deliveries are generally associated with higher risk procedures and that's consistent in this data where you see 117% higher odds than compared to a vaginal delivery. Similarly, we find complicating conditions and pre-existing complications are associated with higher odds of in-hospital delivery-related death. Pre-existing conditions like diabetes, sickle cell anemia with crisis, hemorrhage, diagnosis at delivery, and substance use are all at higher odds for mortality. When looking at severe maternal morbidity during this analysis, again, we use the CDC's methodology when looking at this. We identified that between the study period and the adjusted prevalence of any severe maternal morbidity, it remains steady with a very slight decrease over time with 177 per 10,000 discharges to 172 per 10,000 discharges. You'll see in the trended analysis a bit of a bump. That is right at the time of ICD-9 to ICD-10 transitions. It decreased around 2019 and flattened somewhat with a slight trend increase when looking at the regression adjusted analysis. It remains flat and not statistically significant. So we'll continue to drill into those outcomes and provide greater insights in some upcoming peer-reviewed journals. We looked at in-hospital severe maternal morbidity related to race and ethnicity, and we demonstrated decrease over the study years for Black, white, and Hispanic women overall, although you can generally see there is still a disparity between races. And we are seeing a increased trend, particularly for American Indian, Asian, and Pacific Islander women. Again, we are drilling into all of these variances, and the outcomes from those will be provided in upcoming releases from HHS. This is an example of drilling into severe maternal morbidity overall, and very similarly, you can see that pre-existing conditions like diabetes have higher odds than those without. We found that patient attributes of comorbidities and complications correlate with higher odds overall of severe maternal morbidity. We again identified preeclampsia, for example, certainly suggests a higher odd of severe maternal morbidity than without. And again, payer does have an effect on patient populations with overall severe maternal morbidity. The COVID pandemic, we have dived very deeply into this analysis. We're looking at this is delivery-related outcomes associated with COVID and their impact. We have run an analysis overall with COVID at any time during the pregnancy and readmissions. Again, that's in an upcoming study to be released by HHS. But overall, we found that similar to the mortality studies, that there hasn't been a statistically significant higher mortality rate during the pandemic period. But for those women who were diagnosed with COVID at the time of delivery, their odds of death were nearly six times greater than those without. And the odds of severe maternal morbidity is 3 times greater during the period than those without. So clearly COVID has an impact on overall mortality and morbidity. So the value of this data, and of course you can all make your own determinations from that, but we find that the value of using overall standardized data, both within this national analysis for HHS and through the second part of their initiative, is that it provides you with uniform information and it's validated. All the data is pulled the exact same way and cleansed so that the artifact has been removed. So that it does provide you with a very unique glimpse of what happens within the inpatient setting. It's every encounter for every inpatient across the continuum, whether that's the emergency department outpatient visits or whether it's the ICU or any other of the ancillary units, we can collect the data from across the continuum. And again, it provides you with a unique snapshot of what's happening to that patient population during that time. This complements the CDC and state maternal mortality review data very well because it provides you with reliable insights for key drivers of maternal outcomes. And the ease of these hospitals in providing the data, because it's an already established platform that hospitals use across the country, it provides a very cost-effective way to analyze standardized data seamlessly. So with that, I will transition back to you, Fran, and the team to support any questions.
Thank you so much, Deb. It's really very useful information, of course, quite consistent with what we have seen. And, I just think about, being an epidemiologist and public health professional for 25 years, probably the most frustrating thing is to look at the numbers and not see the move in the direction that we would like them to be for many communities. And with that in mind, I'd like to pose the first question, and perhaps we'll direct that towards Mariah. If you could maybe reflect upon some of the amazing and valuable data that Deb has presented and share with us what you see as sort of being the response and sentiments from the perspective of patients and families and community-based organizations in light of the need to collect more data and to be able to really utilize the data that's being collected.
I think it points to some really important factors that the data collection that is currently in existence and accessible to community-based organizations and families is pretty non-existent or pretty hard to access. And so it looks at the project that Deb is doing as something that's going to be accessible to just about everybody, which is very good. And especially if it's provided in the way that Deb has provided in her slides, that is very understandable. And that's a key point for community and for the general public, is to present data in a way that's understandable for everybody to read and to get the information from. But one key point that we always have to remember is that when we're talking about community-based organizations and community members, is including them and their perspectives in the data, how we're collecting data and in data collection to begin with. We're collecting data in one setting, but it doesn't tell the whole story. So how do we tell that whole story of data collection? And there's many ways to do that. So linking systems like what Deb has and has created to groups like the group that we have here with our data sharing network that's collecting that CBO, community-based organization data. Now we have a clear picture to paint on what's happening in families' lives and what's going on in the hospital setting, and then what's happening in that external setting. And it helps to show exactly how families are interacting with healthcare and how they interact with the settings and the social determinants of health impact their life. And that can go into building those systems and policies.
Really very valid points. Jeff, you want to make any remarks on that? I mean, it makes me sort of jump instantly into, okay, EHRs, we know the data that we're collecting today predominantly within HR, but I understand that there's sort of a diversification of data and bringing in various sources that could then directly contribute to some of the aggregation that Deb's team is working on, right?
Yeah, I think Deb's data is great. Not to downplay it, I didn't find anything surprising in the data, but what it did was I always assumed that I knew what the problems were. And I think we've always assumed we knew what the problems were, but she now, with the data, are able to confirm those assumptions, which really, really gives us the ability to dig in deep and gives us the security in knowing that we are actually going after the right things, that we're not, going down a path. So I think it's great information to have in confirming that. When I look at what we do from EHRs, I really think there are a couple factors that play into the data and how it's collected. And really, in order to if we want to make it, if the goal is to improve healthcare, just across the board and save some money doing it, but more specifically maternal healthcare, you actually need a complete data set. And that's what we're hoping to do with the EHR, is really to make sure that we have that complete data set. Any data that's collected on paper, and then stored in charts, locked in the file cabinet or in the HM department, it's accessible, but it's really hard to harvest that data. By digitizing all of healthcare, then we actually make it much easier to get in and query that data. And Deb, is showing the value of doing that with her data. And that really gets into the whole thing that I think we as an industry have been struggling with for quite a while now, is now that we've digitized it, is we all want access to it. So interoperability is one of those key things that we're building, or we've been trying to build towards. That hasn't always been voluntarily done. It hasn't always been easy to do, but the 21st Century Cures Act did finally put some mandates, and a time frame around making sure that we, as an industry, actually moved towards that path, and that we chose a standard for that interoperability. But interoperability, to some extent, in my mind, is a be careful what you wish for thing, because now you're going to, if you had some of the data before and you were running at 1 million miles per hour in your clinic, or if you were the nurse running at 1 million miles per hour on a full bladder in labor and delivery, getting more information, having more information presented in front of you just makes your job a little bit harder to do. So it's incumbent on us in the industry, the EMRs and everybody who has the data, that we take that data and we transform it, we deduplicate it, we clean it up, and then present it back to the clinician in a way that makes it easy for the clinician to actually act on that data, that we provide it back not as clinical distraction or another clinical task to do, but as clinical decision support. And that also then gets into then what data do we want to collect and how should that data be collected? I think, in the industry, again, it was the EMRs, we've all created our own maternity systems, and frequently those were driven by what the client needed, or the client wanted, but also we look to the professional organizations and the way that we have done our job, traditionally, and replicated to some extent some of those paper processes. But really, if we want to make that, the clinical impact, then we do need to make sure that we do have some standardized definitions of what that quality is. And sometimes, I had 22 years of clinical practice. Sometimes the quality measures that I was judged against, I was kind of going, wait, what? That? No, this is what we think of. This is what we consider as this is what quality is. It wasn't always clear to us what the measures were, who wanted them. And there's a lot of different organizations weighing in on that. So some national standard for that definition of quality that takes into account the professional organizations, as well as the accrediting organizations and the federal organizations, and all that would go a long distance towards that. So if you tell us what we need to collect, we'll do it. But we need some definitions. Sorry, Fran.
No, I know you're spot on, Jeff. I applaud you for your remarks there. And it just makes me curious, Adriana, from the standpoint of, legislation and creating for policy that really puts us in a position of doing more, right? In terms of, on the one end, we say there's been a lot of progress with interoperability. Today, the argument is that it's not the technology, it's the people that are holding us back. How do you see that being reflected in some of the legislation policies that are being discussed on the Hill? And what are some things that we should be looking out for and considering in relation to the things that Jeff has described?
Yeah, so I would say, in regards to the Hill, we definitely, I think, try to be responsive, but sometimes we're very reactive. So, as you saw, a lot of the legislation that came down, or this conversation started with, the formation of different caucuses on the Hill in 2015 with the Maternity Care Caucus. And then in 2018, we had the Preventing Maternal Deaths Act, which really helped us provide the federal groundwork to give maternal mortality review committees, the federal resources they need to investigate every single maternal death. I think when it comes to standardization, one of the things on the Hill that really gets complicated is that you have thousands of staffers that don't have, Jeff's experience, don't have Mariah's experience, and they're trying to translate these complex health conditions, ideas, things that are happening on the ground in your clinics, in your hospitals, and make effective policy. And I think what we've seen with some legislation is that sometimes I feel like we're behind the curve because, for example, CDC recently released a study and the data we got from the MMRCs were from 2008 to 2017. And that's great, and I would say, the data that Deb presented made me even more excited. It was like, wow, we got 2020 data. This is awesome. And so it's really, I would say with standardization, I think a lot of times Hill staffers we defer to the federal authorities, and we defer, to the agency, the trade organizations to help us be up to speed of where we need to be. But I think one of the hardest policy challenges is being responsive to the current situation, because sometimes what we see with data is, we have all this great data, it might be lagging behind just because of how it's reported, but then also, then you need to get it in front of Hill staffers where they can understand it and understand, the scope of what's going on. And so I always think on our end, the biggest challenge is being responsive, not reactive, and really trying to, understand these complex topics when you have, a portfolio that's a mile wide and an inch deep, and you're just going, to the next crisis. So I do think we really rely on a lot of the federal agencies officials and the experts to tell us where we need to be. And, when things aren't working efficiently, I think the biggest help is concrete policy solutions, because I think that's what's also sometimes gets delayed, is that staffers are just, trying to go back to basics and figure out how to implement this, when really we need the concrete policy solutions to get something to Ledge Council, get it going, and then work with committees, to really put forward a solution that can help standardize data, because that's something we're really trying to do, I would say, on the Hill continuously.
I think you touched on two really key points there. One is standardization. There's not a standard reporting or standard metrics across the board that are tracked. And so that hurts, especially when we're doing, infant mortality reviews and maternal mortality reviews. Each state, each county, we all have different metrics that we retract. There's standardization on forms for the death certificate forms, but when it comes to what each county reports, what each state tracks and reports, what's important to each county, state, and region, or even HHS region, it's different. And then the data, what is considered current data, we really have got to do something about that. It is not okay for current data to be 5 years old. We do not do a good job with that in our country. We really have to do better with what is considered current data. When we're looking at maternal death and we're reviewing cases that are from 2018 or 19, and we're in 2021 coming into 2022, we're behind the curve. We really need to do better when it comes to data. And that's something that we'll get there. And now that we talk about it, we'll get there, but we've got to really put a fire behind that and work hard.
Right. You hit on a point that I think we struggle with from the EMR side. Frequently the data, it comes from 50 different states that have 50 different, laws or interpretations. And as we look to create workflows for the collection of that data, sometimes it makes it difficult or time consuming to get those workflows actually presented to the users in a meaningful way. When we have to deal across 50 different state lines that require it to be sent in X, Y, and Z format, or have different, data points, or call those data points something different. And typically frequently what that ends up is just another digital form put in front of the provider, the doctor, the nurse, with another box to check off. And none of us went to med school or nursing school or pharmacy school to do the EMR. We went to take care of patients. So having that standardization would at least enable us to work across those state lines and get those workflows out quicker and sooner. But more importantly, it might enable us to do it so that it's not just another form with another box to check, that we've identified the right person who can collect that data. Should it be the doctor? Should it be the nurse? Should it be somebody in the office staff? But we've also done it as a more natural or organic part of the workflow, is part of taking care of the patient and not just filling out boxes. If we can figure out how to do it naturally, so it feels, more comfortable for us to do, we'll start to get, I think, better data, and we'll also start to see satisfaction and adoption with the EMR systems that we have that we sometimes are lacking still.
Let's dive a little bit more here, because a lot of the data that we sort of intuitively begin to think about is very inside of the system, sort of clinically driven by providers themselves, right? Sharing data across to one another. There was a question that came from the audience and actually was being directed towards Deb. So maybe if you could begin to kick us off with this one, Deb. The question was, have you considered the impact of physical inactivity or maternal on maternal mortality, especially diabetes, hypertension, perhaps, other insights related to the state of the mother that is something that's occurring outside of the system, that's not appearing in the system, that may be even perhaps coming from personal generated data as opposed from data deriving from the clinicians?
No, absolutely, and happy to kick that off. And the data we provided to you was just a sliver of the data we're providing to HHS. And we are absolutely diving into things like obesity, for example, and those pre-existing conditions, and what is the impact on this patient population. And what we showed you is just that inpatient component. Mariah, I think you tipped on it, that snapshot of what's happening in the inpatient setting is giving us a bigger picture of what's happening on the outpatient setting. So we have to we have to bridge that gap between the inpatient and the outpatient data in order to really get that population health impact. So yes, we absolutely have to dive into what are these health factors that are influencing overall complications, lifelong complications that are leading to likely the mortality rate we're seeing from those MMRCs. And how can we help with those community agencies to reach the patient population to really help them better affect their health. And that's why this initiative is actually tied to Mama's Voices and those community organizations, because you have to hear the voice of those that are being impacted, the people that are whose health is impacted downstream. We know that the life of the mother is a massive impact on the overall health of the nation, because they're bringing these children into the world, and if they bring them into the world impacted by poor health outcomes because we didn't do anything about it, then shame on us.
Very, very valid points there, Deb. I'm sort of curious, when you think about the data being collected, for example, you mentioned that obesity is an area where you want to put a focus. And I find that quite interesting, because one of the research initiatives that REACH is focused on is working with a team out of New Jersey Perinatal Institute, where we've been finding that the conversation with patients, with women around obesity and weight management is not happening during pregnancy. It's not happening during those visits. What are your thoughts, or what is your anticipation in terms of the type of additional data points that are currently not being pulled into the data that you're analyzing? What are your thoughts around what those might need to be? And I'm actually opening this up to everyone. Curious to know from Mariah and Jeff, as well as Adriana's perspective, what are some of the added data points that are just sort of non-traditional that we need to start looking at, and directives that we need to start giving in terms of the way that we're practicing care for pregnant women?
I'll
start by jumping in. Oops, sorry,
no,
Jeff. I'll just throw out social
Deb.
determinants first. Yeah, social determinants, once we're able to seamlessly measure those and bring that information into the data, in addition to the outpatient information that is not linked to this, and how that patient population interacts with their provider and within their community, both in the prenatal setting or in the overall health of the woman, and then post-discharge, how are we caring for that person and that family once we've identified that they have health outcomes that need to be addressed. So social determinants, I think, is going to be a key player in helping us to be able to crosswalk some of those insights. I'm sorry, Jeff, I didn't mean to.
No, that was great. And actually, I'm going to tag onto that and just say that I think that, the hospitals tend to be these monolithic kind of organizations and they're capturing all the data on the deliveries, but really the delivery is the last day of the pregnancy, or the last few days of the pregnancy. The pregnancy is actually 9 months, and that 9 months of care typically happens in the outpatient clinic. Now, about 46 to 50%, I think, of doctors are employed by health systems. So we are hopefully collecting some of that outpatient data, but a lot of that outpatient data is sitting in smaller EMRs that frequently don't get tapped into, or that we don't tap into, because a lot of the quality and health initiatives have been pushed towards the hospitals and in large organizations and IDNs. So having that outpatient data, I think, is really critical, especially as we look at patient safety. All those little things that may have been building up in the outpatient venue that we didn't see. Social determinants of health, I agree, is also a big thing. Where I struggle with is that we can't collect all those social determinants of health within the EMR. As a clinician, it's going to be really hard for me to know that the patient's boyfriend, has been in prison 3 times, is currently a drug dealer, and has a history of abuse. So how do we actually bring together maybe the other systems like law enforcement or social systems that need to be a part of this huge data set? because that will impact the care I give, but getting to that level of detail in the patient's life as a clinical provider is going to be really hard for me to do, especially considering that I've got maybe 30 other patients I need to talk to, you know.
It may have negative impact on the patient as well. At least we forget the privacy rights of patients. Mariah, I saw you were ready to jump in on this one.
Yes.
So I'm gonna let you please share.
This is where community-based organizations shine. When you have families who have challenges, whatever it may be, and that doesn't specifically mean an economic challenge, just any family who has any type of barrier or or challenge in their health, a community health worker is ideal to pair them with. Especially a family who has any social determinants of health box checked, who maybe has a box in that family tension tool, who we've identified as having an abusive spouse, or a spouse who may be in prison, or a spouse who has significant challenges. The last thing that we want to do is involve police or social services, because we're going to break the trust with that family, and they're not going to come back, and they're not going to talk to us again or entrust us with that very intimate information. And when we're talking about social determinants of health, we're talking about intimate pieces of our lives that we don't really share with people. We're talking about very personal things. And so it's very challenging for a lot of families who experience these on a daily basis to share that information with people that don't look like them, people who have typically challenged them in the past, people who they've had negative interactions with. So if we're talking about a family who maybe's had a bad interaction with social workers in the past, the last thing they're going to do is tell a social worker they're having challenges putting enough food on the table. If they are a family who's had negative interactions in the past with a nurse in a high-risk medical clinic, the last thing they're going to do is divulge all this sensitive information to them. So we really need to be careful with how we ask these questions and who we refer to, and community health workers can bridge those gaps. They can gather that social determinants of health information, and they can address all of those social determinants of health issues. And they are built into the Omnibus Act, they're built into the American Recovery Act, they're built into all of the acts that have been passed or on the table in both legislative bodies in the past 8 years. And so we need to really focus on those and highlight those.
Thank you so much, Mariah. You just hit on some bells that are so important. And Adriana, I have to bring you into this, right? I mean, even your background, let alone your role within on Capitol Hill. I love to hear you talk to us a little bit about the perspective of privacy and security, rights of the user, the rights of the consumer. Tell us what you have seen, what your office is representing right now that may be presented on the Hill.
Yeah, definitely. So I would say that, one of the biggest, I guess it kind of goes without saying, but, some of the biggest initiatives that I would say, my short career on the Hill that I've seen make the biggest impact are pieces of legislation that are bipartisan. Like, that goes without saying, hands down. Building off of that, I think the privacy and security aspect becomes even more, of a kind of glaring thing in the room as we write policy, because we've seen data breaches, we've seen, things where complete, medical systems get shut down. We've even seen good pieces of legislation get stopped because of privacy concerns that might not even relate to, the maternal health sphere. But for example, last Congress, our Newborn Screening Save Lives Act actually got stymied in the Senate because of privacy concerns. So these things do come up. And I think one of the, I think it's on everyone's mind, but it's also, I think, from the beginning, addressing them as we move forward with innovative solutions. I work very closely with, CDC, NIH, all these different bodies, HRSA. And I think that there is a way to address it on the agency level and how we, collect that data. But then it's also important when we're making legislation to build that in. For example, my boss, Congresswoman Allard, Rep. Castor, and Rep. Mullen just introduced the SHINE Act, Stillbirth Health and Improvement in Education Act. And one of the things that we built in when we were looking at collecting data on stillbirths that happened was that it was, with the consent of the family. Now, for someone who's on the other side of, this data collection, it's like, it's private. We're really protecting the patient, but someone looking at that legislation on the legislative side, a staffer might need to see that, that this is with the consent of the family in order to get their boss on board. So I think it's something that, I believe working with the practitioners and those collecting this data that we are doing very well and cognizant of. But I think as, we evolve, I think we're going to have to build out more policy that's responsive to this, or we're going to have to look at innovative systems that are, protecting privacy and security, and then also making sure we convey that as we write legislation. Because I think sometimes things that are a given on the practitioner side do not translate on the policymaking side. And I think that's just, education, not just of staff, but of members and senators and representatives, that they know that this is something that's always at the top of mind as we kind of try to build out these, integrated systems.
Adriana, thank you. Mariah, Deb, Jeff, this has been amazing. Thank you all. I do want to put a plug in to remind everyone, when we start talking about things like social determinants of health, it's almost like it's a code word for poverty. And we know with maternal health in particular, that income has proven to not be one of the factors that are contributing to the major challenges that are being faced. In fact, many of the lives that have been lost have been from incredibly educated and individuals of high income. And this is also very true amongst those who have suffered from severe maternal morbidities. So I'd like to keep that in mind as we start to think about what data we're looking at and make sure that we're asking the right questions. For all of you, thank you so much. We're getting so close to time. It's my honor now to say, to introduce actually Elizabeth Frazee, who's going to join us here at the end and wrap things up for us, and say thank you once again to our panelists. Thank you.
Thanks so much, Fran. And what an incredible program. I learned so much, and thanks so much to all of our informative speakers. We're seeing Congress, administration, clinicians, technology companies, advocacy groups, community-based organizations, and other patient groups working together, and it's making a difference. And that's what's so phenomenal about this collaboration and the Match Coalition. We launched not even a year ago. And while much progress has already been done in Congress, as Adriana pointed out, they've been working on this since 2015. It takes a long time to get things done. And we're positioned now at a very exciting time with the Momnibus being included in the Build Back Better Act, Representative Davids' legislation being part of that on data. And we're seeing that data has to be linked, it has to be standardized to build the best systems and policies, and that more progress needs to be done in this area. So we've got our work cut out for us, but I know we're up for the job, and we will continue to work together as a coalition, putting together more programs, working with policymakers. And in the meantime, I encourage everyone to do what Adriana suggested: reach out to your lawmakers, let them know how you can help, and encourage them to keep doing this important work. So until next time, be well, work hard. Thanks so much, everyone.
Thank you all so much for joining us for our virtual discussion today. If you missed any of this, or if you think there's anyone who would value from seeing this, we'll get this posted to our website and send this out far and wide. Enjoy the rest of your day. Happy Global Health Equity Week, and take care. Thank you all so much.